G'day, I'm Dr. Paul Mason, and welcome to Germs and the Big Lie, unmasking the root causes of heart disease. Today, we're going to reveal what's the real cause of atherosclerosis, the process leading to fatty deposits inside your arteries. You're going to learn about what happens to rabbits when they get injected with LDL, which is not much, and the difference between dental plaque and coronary artery plaque, which again is not much, except perhaps for the location. We'll also see how pigs who have bacteria that can cause gum disease injected into a vein develop heart disease in a process which actually mimics what happens to many of us every day when we brush our teeth. You'll also see that clotting or thrombosis may not play a huge role in how thrombosis starts, but it sure can make a difference to how it ends. And amongst all this, you'll learn about the key role that the chemical process of oxidation, which is like rust inside your body, plays in causing atherosclerosis and heart disease. And we'll touch on many of the different environmental toxins which are associated with atherosclerosis, including microplastics, forever chemicals, pesticides, and heavy metal pollutants. In summary, you will learn that both oxidation stress and infection can damage the inside lining of the arteries, which is coated with something called the glycocalyx. And this is what starts the process of atherosclerosis. Before we get into all of this, however, we need to do a little bit of myth busting. According to the Heart Foundation of Australia, the nation's peak authority on cardiovascular prevention, high cholesterol is a leading modifiable risk factor for coronary heart disease. In fact, their website clearly states that cholesterol can stick to the walls of your arteries and create blockages. This is essentially the lipid heart hypothesis, which is the theory that elevated levels of cholesterol in the blood, largely due to dietary saturated fat, lead to fatty buildups in arteries called atherosclerosis. Based on this theory, the American Heart Association still recommends limiting saturated fat intake to less than 6% of total calories. It was the Austrian-British philosopher Karl Popper who said that if the predictions made by a scientific theory are falsified, in other words, proven wrong, the theory dies, and the predictions made by the lipid heart hypothesis have been proven very, very wrong. Let's begin with the underlying assumption that dietary saturated fat increases LDL, a claim echoed by the Australian Dietary Guidelines. This belief, which is something of a sacred cow that cannot be questioned, has in fact never been proven. Rather, when it has been tested, as it was in this randomised trial, it has been conclusively disproven. This study looked at the impact of 3 fats, and coconut oil containing 94% saturated fat was found to reduce LDL, not increase it. The fact is, the saturated fat content of various fats and oils seems to bear no correlation with their effect on LDL. But the debate on whether or not saturated fat increases LDL becomes all but meaningless anyway when you consider there is no compelling evidence that high LDL levels cause heart disease anyway. This systematic review looked at 19 prospective studies with over 68,000 participants, and subjects with the highest LDL levels actually lived the longest. In fact, 16 of the 19 studies found this relationship. Data from the International Interheart study reveal that 72.1% of individuals who were admitted for heart attack actually had LDL levels below 3.4 millimoles, or 130 milligrams a decilitre. And this study found that statin-taking subjects with the lowest cholesterol levels were in fact more likely to die. Predictably then, large-scale randomised controlled trials, the best form of research we have on this topic, have repeatedly found that lowering saturated fat intake does not reduce heart disease. In other words, atherosclerosis is not caused by saturated fat in the diet. This 1965 study, some heart attack survivors randomly received a supplement of corn oil. After 2 years, 48% of those receiving the corn oil had had a repeat heart attack, compared to only 25% not receiving the corn oil. The corn oil almost doubled the risk of heart attack. The next study was much closer to home, the Sydney Diet Heart Study. This was a randomised control trial examining the effect of replacing saturated fat with polyunsaturated fat in men who'd had heart attacks. And it found that in those Australian males who increased their intake of polyunsaturated fats, well, they were more than 62% more likely to die. A similar finding to the Minnesota coronary experiment. This was a double-blinded randomised controlled trial on more than 9,000 men and women. And again, subjects who replaced saturated fat with polyunsaturated fats faced an increased risk of death. Now, predictably, subjects taking the seed oil, the extra seed oil, did see a lowering in their LDL, not because of changes in their saturated fat per se, but because this is what certain components of seed oils do. They interfere with normal cholesterol absorption. The greater the fall in the LDL, however, the greater the increase in mortality. As clear a repudiation of the lipid heart hypothesis as you will ever see. Increased cardiac issues with increased seed oil intake was again shown to be harmful by the Women's Health Initiative study. Published first in 2006 on over 48,000 females, this modern-day randomised controlled trial found that reducing saturated fat intake increased cardiac events by 26%. Not just associated with, but caused. And that's the whole point of these randomised controlled trials. They actually are able to demonstrate causality. You may be aware that the lipid heart hypothesis was born out of an experiment in which rabbits were fed cholesterol-enriched seed oil. And so if a rabbit study is good enough to birth the lipid heart hypothesis, it should be good enough to put it to bed too. So this rabbit study, over a 5-week period, were fed a high cholesterol diet, except this time without the seed oil. But then some of the rabbits also had LDL injected directly into their veins. And so after 5 weeks, the rabbits were euthanized and their aortas were examined for atherosclerosis. And guess what? The group injected with the LDL, well, they had less fatty deposits. So much so that the authors of the study stated that LDL was, and I quote, an anti-atherogenic particle. In other words, it seemed to prevent atherosclerosis. What this really says is that the findings of atherosclerosis in the original studies by Nikolay Anikov were in fact likely to have been caused by the seed oil, not the cholesterol. So then, if saturated fat and LDL don't cause atherosclerosis, what does? To begin to answer that, we need to consider the various stages in the progression of a typical atherosclerotic plaque. To begin with, I need to make a key point. There actually is a significant amount of LDL in atherosclerotic plaques, or at least the constituents of LDL after it's been broken down. And this is incredibly important to understand because it explains the obsession of mainstream authorities with LDL. Sure, they may be mistaking correlation for causation, as in, no, this cat did not crush the roof. But at least we can understand how they may have got the idea. Let's begin by looking at the role of infection in atherosclerosis. Now, the potential for infections to cause heart disease has been understood for a long time. In fact, patients admitted to hospital with bacteria in their blood are 18 times more likely to have a heart attack or stroke within the next 30 days. That's an 1,800% increase. And for reference, current smokers have an increased risk of heart attack of about 2.5 times compared to non-smokers. This 2011 study examined 42 surgically removed atherosclerotic plaques and found DNA evidence of bacteria in all of them, while another 2014 study found that 95% of arterial biopsies from patients with gum disease also had detectable bacterial DNA. But why the focus on gum disease? First of all, epidemiological research finds that people with gum disease have an increased risk of coronary heart disease, about 4.5 times greater. Also, the bacteria that commonly cause gum disease, like Porphyromonas gingivalis, are very common. Some studies suggest it's found in the mouths of more than 50% of the population. Furthermore, these and other pathogens frequently enter your bloodstream with teeth brushing or even eating. This study finding bacteria in the blood of 38.5% of children following toothbrushing. Now, that doesn't mean that the only source of infection is from the mouth. Numerous infections can result in bacteria entering the blood. This study of more than 6,000 cases of bacterial blood infection reported numerous causes, from bladder, kidney and gallbladder infections to infections of the liver, lungs, gut, soft tissues, even our joints. The fact is, basically any infection, most anywhere in the body, has the capacity to enter your circulation. It just so happens, however, that the oral pathogen Porphyromonas gingivalis is one that is the most strongly associated with heart disease. So pigs were injected with this bacteria, Porphyromonas gingivalis, 3 times a week for 5 months. 2 weeks after the last injection, they were euthanized and their heart arteries and aortas were examined. And pigs who were injected with the bacteria developed significantly more atherosclerosis compared to control pigs, as you can see on the screen. Another key point which I need to make is that other types of infection, including viruses and fungi, have also been strongly associated with heart disease. For example, the UK-based biobank study found that the risk of developing heart disease within 5 years after being hospitalised with chronic viral infection was 57% greater. Fungal infections too are quite common inside atherosclerotic plaques. One study evaluated 41 diseased arteries that were removed during bypass graft surgery and found evidence of fungal infection in 11 or 27% of them. And this study raises another significant point, the difficulty of diagnosis of these infections. You see, even when they had the infected artery physically in front of them, standard culture testing was only positive in 1 out of these cases, and direct microscopic examination didn't detect anything at all. The point is, fungal infections are difficult to diagnose, and as a result, I suspect they're heavily underdiagnosed. Dr. Jens Ponekow, an ENT surgeon, used novel methods to test for fungus in 210 consecutive patients with chronic rhinosinusitis, techniques that aren't readily available to us in clinical practice. And 202, or 96% of them were proven to have fungal involvement. The fact is, we don't have access to this type of testing in clinical practice, and as a result, most cases of fungal infection remain undiagnosed. There's also growing evidence of an association between chronic rhinosinusitis and cardiovascular disease, with 2 large cohort studies finding an apparent increased risk of about 50%. And it's important because there's a synergy between bacteria and fungi. They're often found in close approximation to each other. For example, recent research reveals that the yeast Candida albicans, also very commonly found in the mouth, can internalise the bacterium Helicobacter pylori, which is most famous for causing stomach ulcers. Basically, Candida can swallow Helicobacter pylori and protect it from the immune system and antibiotics. Accordingly, this makes Helicobacter pylori difficult to treat with antibiotic therapy alone. And while there's not been much in the way of testing prescription antifungal agents as adjuncts, there's been some high-quality research on the addition of probiotics to the treatment for Helicobacter pylori. This meta-analysis, for example, found that the probiotic Saccharomyces boulardii increased the success rate of standard treatment of Helicobacter pylori by 11%, which is quite significant, all the while reducing treatment side effects by half. Now, this is of more than just academic interest. This study, for example, found that more than a third of ischemic heart disease patients were infected with Helicobacter pylori, while this paper found Helicobacter pylori DNA in more than half of surgically removed atherosclerotic plaques. The point I'm making is that we should be mindful that it's very plausible that a combination of fungus and mixed bacteria may commonly contribute to atherosclerosis. So now the question is, exactly how can infections be so damaging to our arteries? It's now widely understood and accepted that atherosclerosis begins with damage to the internal lining of the arteries, the layer called the endothelium, which is for the most part made up of a single layer of cells. It is not, however, bare like you see in this picture. Rather, it has a fur-like coating, which we call the glycocalyx. You can see here in yellow the single layer of cells that makes up the endothelial layer, and on top you can see this endothelial glycocalyx. Discovered in the 1960s through electron microscopy, the glycocalyx lines every single blood vessel in your body, and it's incredibly important to your vascular health. It also just so happens that infections can destroy it. The glycocalyx serves several essential roles in our blood vessels. It acts as a gatekeeper. It lets tiny essentials like water, electrolytes, and nutrients pass through, while at the same time blocking larger particles like microbes and LDL. Those hairs also fend off clots by blocking platelets and inhibiting coagulation pathways in the blood. Those hairs are packed with antioxidants like superoxide dismutase, which can neutralise harmful free radicals like reactive oxygen species. It can also elegantly control blood pressure. Flowing blood bends the hairs much like seaweed sways in a current and stimulates the endothelial cells to release a compound called nitric oxide, which, in addition, is also potent at inhibiting blood clotting. It also relaxes the muscles within the artery locally to help regulate the blood pressure. In short, the glycocalyx is our artery's front-line defence. And when you hear the term endothelial dysfunction, it almost certainly means that the glycocalyx has been damaged. And the problem is infections of all flavours, virus, bacteria, fungi, protozoa, are very effective at destroying the glycocalyx. Most infections through inflammation result in upregulation of proteases, which are enzymes that degrade proteins. And amongst their targets is the glycocalyx. We have proof of this in several human studies where levels of particular proteoglycans called syndecan are measured in the blood. Normally, levels of free syndecan should be very low, but if the glycocalyx is damaged, it gets released from the glycocalyx, sheds off the lining of our blood vessels, and enters the circulation. And several studies show very high levels of free syndecan in the blood associated with infection. A normal level should be less than about 30 nanograms a mil, but in infection, it can exceed levels of 1,000 nanograms a mil. And damage to the glycocalyx can be, as well as being severe, it can be very rapid. This mouse study found that injected bacterial toxins called lipopolysaccharides were able to reduce the thickness of the glycocalyx by more than 98% in just 24 hours. This was a study in 13 human subjects who received low-dose intravenous bacterial endotoxin, again lipopolysaccharide. There was a 50% reduction of the height of the glycocalyx after just 4 hours correlating with the presence of increased components circulating freely in their blood. And while the general inflammation upregulates these proteolytic enzymes, there are other specific contributors to glycocalyx damage that other infections can inflict. For example, influenza A and B infections secrete an enzyme called neuraminidase, which directly cleaves a core component of the glycocalyx. And this likely explains why the risk of a heart attack in the weeks after flu is increased by 6 times. Dengue virus too secretes a protein which is able to uniquely degrade the glycocalyx, with the rate of heart attack in the week after diagnosis of dengue fever being increased by more than 13 times. So hopefully by now I've convinced you of 2 things. 1, damage to the glycocalyx can trigger the start of the atherosclerotic process. And 2, that infections can damage the glycocalyx. Broadly speaking, there's another cause of damage to the glycocalyx that we need to address, and that's oxidative stress, not least because virtually all infections also cause oxidative stress. Oxidative damage happens when electrons are stripped away from molecules, and this creates unstable or reactive species that can attack nearby cells, like proteins and fats. This can set off a chain reaction of molecular damage, a bit like how rust spreads through metal. In everyday terms, you can think of oxidative stress as a kind of internal rusting that happens inside the body. And as the name suggests, it increases in the presence of oxygen. Which is perhaps why this study conducted in Melbourne found that providing oxygen to heart attack patients when their oxygen levels were above 94% actually increased their risk of recurrent heart attacks in hospital by 6 times. Additionally, 6 months after, MRI measurements showed that the volume of the damaged heart muscle was 35% larger in those subjects who had received the supplemental oxygen. The fact is, as far as vascular health is concerned, and especially the glycocalyx, oxidation is bad. And this is why a condition called Gilbert syndrome, which results in high levels of a potent antioxidant, bilirubin, significantly reduces the chance of cardiovascular death. This large population-based cohort study found individuals with Gilbert syndrome had their risk of dying reduced by half. Now, oxidation can be propagated in the bloodstream through multiple mechanisms. We have small reactive molecules such as superoxide and hydrogen peroxide, and they can induce oxidative stress, but they're typically short-lived, so their effects are largely confined locally near the site of production. Surprisingly, however, lipoproteins, both HDL and LDL, can transport oxidative equivalents over longer distances. Now, HDL is relatively resistant to oxidation, especially compared to LDL, due to its high antioxidant content. This means that LDL serves as a more significant long-range carrier of oxidative stress. And this circulating oxidative stress can directly damage the endothelial glycocalyx and accelerates the development of atherosclerosis. This hamster model study found that administering oxidized LDL could degrade the glycocalyx by 60% in only 25 minutes. And proof that oxidation was responsible was shown when pre-treatment with antioxidants was able to completely abolish this effect. Likewise, this in vitro study on human umbilical cells showed that oxidized LDL could thin the glycocalyx and also increase vessel permeability. And here we can see that oxidized LDL was basically completely absent in healthy subjects, in stark comparison to those with coronary artery disease. This directly challenges the notion put forward by some that LDL is never harmful. The key thing to remember is that LDL can carry oxidation long distance through the circulation. It can, but only if it's been damaged by oxidation. It has to be oxidised LDL. And there's a test called LDL subfractionation, which we can do to assess this. Compare the single healthy peak of LDL on the left compared with the damaged 4 peaks on the right. Those extra peaks representing damaged populations of LDL. Now remember how most patients with heart attacks have normal LDL levels? Well, most patients with heart attacks have abnormal glucose levels. This research from 1962 concluded that 73% of heart attack patients had suboptimal glucose levels. And there's a well-established link between high glucose and oxidative stress through multiple mechanisms, including through the increased production of reactive oxygen species by our mitochondria. One striking example of the interplay between oxidation and high glucose comes from a study examining the effect of consuming oxidized oils like seed oils. Now, first of all, understand that the consumption of oxidized oils results in the oxidized compounds being packaged into another lipoprotein called chylomicron, whereupon it enters your circulation. And this too, no doubt, goes some way to explaining the poor results of trials like the Women's Health Initiative, where encouraging seed oil consumption increased heart disease. So this study measured the level of circulating oxidation stress in subjects following the consumption of oxidized linoleic acid, which is an omega-6 fat. And the two left columns represent the subjects with normal glucose levels, and the right-hand column shows subjects with high blood glucose levels. Not only were the oxidation levels much higher in the group with poor glucose control, but the oxidation products persisted for 3 days, which was 9 times longer than those with normal sugar levels. Not surprisingly then, high glucose levels also result in the destruction of the glycocalyx. This study found a 50% loss of the glycocalyx after exposure to high glucose levels for only 6 hours. And I really can't stress this slide enough. High blood glucose, especially oscillating glucose, is bad for your arteries. And it's maddening when I see so much effort being put into putting people on statins and things like that, while ignoring the elephant in the room that is hyperglycemia. Now, moving on, there's numerous other potential sources of oxidative stress, and all of them are bad for the heart. Take particulate pollution, for example. Particles are able to pass through the lungs, which are quite permeable, and enter our circulation, whereupon they can cause significant oxidative damage. This explains the UK Biobank study findings that Britons living in the most polluted areas were 27% more likely to develop heart failure. Heavy metal pollution like lead is particularly potent, lead atoms being just the right size to be inhaled and enter the circulation. In fact, this study from 2018 concluded that 1 in 6 deaths, or 18% of the 2.3 million deaths occurring annually in the United States, are attributable to lead. And remember, it all comes back to oxidation. We also have to consider pollutants that we essentially ingest, such as mercury or microplastics. After ingestion, they can both contribute to oxidative stress and atherosclerosis. For example, this study from 2024 found that out of 257 surgically removed atherosclerotic plaques, 58.4% of them contained polyethylene, and 12.1% also contained polyvinyl chloride. The plaques containing these microplastics were significantly more inflamed and perhaps more significantly, were associated with a 4.5 times increased risk of major adverse cardiovascular events over the following 34 months. There's also growing evidence linking exposure to per- and polyfluoral alkyl substances, commonly known as forever chemicals. These contribute to cardiovascular disease and oxidation stress. The point is, our modern environment is not what it once was. Amongst inhaled particulate pollution, leaching amalgam fillings, pesticide-laden foods, PFAS chemicals, microplastic contaminated water, we're under oxidative attack like never before. Now would be an appropriate time to review the role of metabolic health in all of this. The US National Health Survey examined adults on 5 metabolic health markers and found that only 12% could be considered metabolically healthy. And the problem was even worse for those over the age of 60, with only 2% considered healthy. The fact is, most of the population is insulin resistant, and insulin resistance both increases the risk of infection and oxidative stress. This was a longitudinal cohort study in which markers of oxidative stress, which included oxidized LDL, remember that long-range oxidation carrier, were compared against insulin resistance. And even after controlling for adiposity, there was a strong correlation between insulin resistance and the levels of oxidized LDL. Numerous studies also show that insulin resistance is strongly associated with oxidation stress through other means. This recent meta-analysis found that treating insulin resistance with lifestyle measures resulted in significant reductions in blood markers of oxidative stress. Putting it all together, this comprehensive meta-analysis of over 500,000 subjects found that insulin resistance was a robust predictor of cardiac events. For each standard deviation increase in insulin resistance, the risk of cardiovascular event increased by about 50%. So to recap, both oxidation stress and infection damage the glycocalyx, which starts a pathway towards atherosclerosis, there being a significant interplay between the two. And when insulin resistance is added to the mix, everything is amplified. Now, after the glycocalyx has been damaged, the next thing we see in atherosclerosis is the aberrant deposition of macromolecules, large molecules, called proteoglycans in the arterial wall. To understand why this happens, consider that the glycocalyx itself is largely made of these macromolecules, a core protein with glycosaminoglycan side chains attached. Now, given the importance of the glycocalyx, when it gets damaged, the body tries to repair it, which obviously requires it to synthesize more proteoglycan. The problem is, persistent oxidative stress interferes with this repair process. This study found, for example, that oxidized LDL resulted in the synthesis of a pathological proteoglycan which could bind LDL 2 times stronger than the normal proteoglycan. The glycocalyx, therefore, ends up not repairing properly, and we end up with clumps of proteoglycan lining the arterial wall rather than forming in the normal glycocalyx. And this proteoglycan just so happens to be especially sticky when it comes to LDL. This then explains the initial retention of LDL in the arterial wall. Remember how we said earlier that atherosclerotic plaques contain significant LDL? Well, this is why. And it's caused in large part by oxidized LDL. Native and non-damaged LDL was not shown to induce aberrant proteoglycan synthesis. So now we've got the infamous LDL into the lesion. Soon after, we get the entry of a cell type called a macrophage, which is attracted by chemicals secreted by smooth muscle cells that exist also in the arterial wall. And these macrophages have something called a scavenger receptor that can recognise and bind to oxidised LDL particles. And this results in the formation of something called a foam cell. Macrophages, which are essentially chock full of LDL. And these foam cells are abundant in atherosclerotic plaques. Now, I need to emphasise that the scavenger receptor on macrophages has a strong preference, almost universal, for oxidised LDL. This study, for example, showed that the ability of macrophages to process oxidised LDL was more than 10 times greater than that for native LDL. And the particular ability of macrophages to ingest oxidised LDL and retain it in atherosclerotic plaques explains the findings of this mouse study. Reduction in serum oxidised LDL level coincided with increases in the size of atherosclerotic lesions. So again, it's oxidised LDL that causes the problem. By now, we're starting to get a lesion that looks a lot like this. It's got a lipid-rich core with a not insignificant contribution from oxidised LDL that's covered over with what basically amounts to scar tissue, which is largely made from protein, which we call a fibrous cap. And there's 2 points to make here. Number one, this lesion is stable so long as that fibrous cap remains intact. And number two, there's likely to be minimal, if any, impairment of blood circulation. Generally, it requires a blockage of at least 40% of the diameter of the blood vessel before we start getting any restriction of blood flow. The fact is that most people aren't getting any symptoms at all from this kind of lesion, which leads us to the next stage in the evolution of an atherosclerotic lesion. Remember those macrophages? Well, after ingesting the oxidised LDL and turn into foam cells, they secrete protein-degrading enzymes. They're called matrix metalloproteinases, and they break down the fibrous cap that's keeping everything nice and stable. We thus end up with a lesion that looks like this, with a very thin fibrous cap. And this lesion is prone to rupture. And if it does, this rapidly results in the formation of a clot, or more correctly, a thrombus, which over minutes to several hours can grow rapidly. First, platelets adhere to exposed collagen, which is facilitated by a large protein called von Willebrand factor, which acts as a sort of glue for the platelets. Coagulation is then activated by another glycoprotein called tissue factor, which comes from the plaque core, and this essentially results in the thrombus. And this process may be repeated several times, resulting in a thrombus with distinct layers. And thankfully, more often than not, the thrombus is only partially occlusive. If you're particularly unlucky, though, the thrombus can completely occlude the vessel, which in the case of the wrong artery can result in an autopsy specimen, such as this one. Now, it's the ability of a thrombus to rapidly occlude a vessel which is the major cause of fatal heart attacks. Accordingly, the aggressiveness of thrombus formation is a key factor in cardiovascular mortality. Remember von Willebrand factor, the substance that acts as a glue for the platelets and allows them to propagate the thrombus? If you remember that and the significance of thrombus, you'll understand why von Willebrand's disease, a condition where levels of von Willebrand factor are significantly reduced, is actually associated with significantly reduced cardiovascular mortality. In this study, researchers deliberately injured the arteries of pigs, and those with normal von Willebrand factor levels, 100% of them developed a thrombus. And those with von Willebrand's disease, none of them developed a thrombus. We see this in humans too. This 2022 cohort study found that those in the lowest 20% for von Willebrand factor levels had a 41% reduced chance of sudden cardiovascular presentation. And this really underscores the importance of coagulation in heart disease, not as an initiating event, but rather as the event that is most likely to kill you. It's also worth considering now that oxidative stress, amongst other things, is a strong procoagulant. It makes your blood clot more. And so the internal rusting that can cause atherosclerosis in the first place can make that atherosclerosis much more likely to kill you. Interestingly, something which we call the triglyceride to HDL ratio is also strongly associated with oxidative stress and clotting. And this explains the superior cardiovascular outcomes that we see in subjects with low triglyceride to HDL ratios. So coming back to our artery, we'll assume that we get a thrombus, but it's only partially blocked. The question is, what do we do about a partially occluded artery? Or more specifically, should you get it stented? This study, published in 2017, randomised 2,287 patients with heart disease to either stenting and drug management or drug management alone. And stenting was shown to have no mortality benefit. And more recently, this 2020 study randomised 5,179 subjects with heart disease to either stenting plus drug management or drug management alone. And again, it found no mortality benefit. The thing is, stenting is really only good for treating a symptom of angina, where it can allow more blood to flow through an artery that's partially blocked. It doesn't address the cause of sudden blockages, and it doesn't reduce your chance of dying. Furthermore, if there's insufficient blood supply to a portion of your heart muscle, over time, the heart can actually make new blood vessels which act as a bypass or a detour. And these vessels are typically small and numerous, which means they're not obvious to us on angiogram investigations. But it does explain why many people who have blockages detected on angiograms often have no real symptoms to speak of. These patients almost certainly have these detours in place, which we more formally call collateral circulation. So coming back to infection, we already know that microbes form a key component of many atherosclerotic plaques. The addition of thrombus to the mix can only make this worse. This lab-based study found that circulating bacteria was incorporated into thrombi as they formed, the authors concluding that bacteria preferentially adhere to thrombi. Not surprisingly then, this study found that 58% of arterial thrombus contain bacterial DNA. And this leads us on to the next element of atherosclerosis progression, the transition from soft plaque to hard plaque. Let's consider for a moment calcific dental plaque. This is in fact nothing more than a mineralised microbial biofilm. Microbes in the oral cavity, primarily a bacteria with some fungi, secrete a protective biofilm made largely of polysaccharides and protein. And this protein, this biofilm, may then passively mineralise via diffusion of calcium and phosphate from saliva, forming a hard crystal called hydroxyapatite. This is the substance that your dentist scrapes off your teeth. And this also explains the predominance of heavier dental plaque on your lower teeth, as this is where the saliva pools. Additionally, while biofilm-forming microbes can utilise any macronutrients, carbs, protein or fat, as energy sources, carbohydrates are far more efficient, and they enable far more rapid production of biofilm. We know full well that soft atherosclerotic plaques can also be seeded with these microbes, the same oral microbes that cause dental plaque. Not exclusively from the mouth, but quite often. And microbes that have the proven capacity to form biofilms in the mouth may also do it in the arteries. and they may also mineralise by the passive diffusion of calcium and phosphate, this time from the blood. And this is the cause of coronary artery calcification. And I speculate that the presence of any calcium in a coronary artery should be considered as evidence of a likely infection. This recent study, for example, identified that atherosclerotic DNA testing found that Streptococcus viridans was present in 42% of 121 specimens, which were obtained after sudden cardiac death. They also found that this bacteria was associated with significant microbial biofilm within the plaque. Another piece of supportive evidence is the identification of distinct coronary artery calcification patterns, typically microcalcifications or calcium sheets. Now, different microbes synthesize different forms of biofilm, which ultimately influence the pattern of mineralisation. Indeed, historical research in the dental sphere has identified different patterns of calcification in the teeth based on different patterns of microbial colonisation. And I think it's very likely that the different patterns of calcification we see in calcific coronary plaques are due to differences in microbial diversity. Now, what about LDL in all of this? The 2025 keto CTA trial on subjects with very high LDL, what we call lean mass hyperresponders, found that the subjects who started the study with no coronary calcification all remained plaque-free. However, those with some coronary calcification did demonstrate continued modest increase, ultimately leading the authors to conclude that plaque begets plaque. And this aligns both with LDL's role in innate immunity and the fact that microbes protected by biofilms are very difficult to eradicate. It's much easier to prevent microbial colonisation than it is to eradicate them once they've settled in. Accordingly, while the high LDL levels working in concert with the rest of the immune system may have been sufficient to prevent any microbial colonisation of arteries, it was insufficient to eradicate microbes already in place. And coronary artery calcification is a poor prognostic marker for longevity. The Framingham study found that coronary artery calcium scores of over 300 predicted a 3.9 times increased risk of future cardiac events, which then begs the question, can we do anything about it? Now, I have personally witnessed regression of coronary artery calcium scores in several patients. However, it's not common, and it's certainly not the norm. There is some early research demonstrating slowing of the progression of calcification, however, that is promising. Probably the most promising evidence arises from studies using aged garlic extract, which perhaps not surprisingly exhibits broad-spectrum antimicrobial properties and biofilm disrupting properties. In this study, 1.2 grams of aged garlic extract was studied alongside normal statin therapy. The placebo group showed an increase in calcium scores over 12 months of 22.2%, while those receiving the garlic extract only progressed by 7.5%. Now, while this is promising, it's certainly not definitive, and it didn't lead to reductions in calcification. So then, what's the approach that I utilise in my clinic when I manage patients with atherosclerosis? Step 1, control your glucose. We've got clear evidence that hyperglycemia, through a variety of mechanisms, worsens atherosclerosis. I recommend you use a continuous glucose monitor and you test for and treat insulin resistance. And remember that changing your diet is the best way to treat insulin resistance. Reduce the consumption of sugars and seed oils, both of which make significant contributions to resistance. And if you are insulin resistant, you should avoid all foods which cause spiking of your glucose levels, as shown on a continuous glucose monitor. In particular, you should avoid sugar. This study demonstrated that simply by reducing fructose intake, which is found in sugar, insulin resistance can be rapidly reversed. 41 children reduced their fructose intake by 2/3, from 12% of their energy to 4% of their energy. And after just 9 days, there were large improvements in their insulin resistance. Number 2, you need to identify and treat nutritional deficiencies. The body, including the immune system, cannot function effectively in a malnourished state. And conditions like microbial overgrowth of the gut, which is very prevalent, contributes to this. Of course, these supplements are likely not to be needed ongoing once you've treated the problem, only while you're recovering. Next, it's also important to identify as best as possible and treat any infections. Now, given how difficult it can be to identify some infections, we might need to consider treating the shadow of an infection. For example, we might identify antibodies produced by the immune system to fight a fungal infection, even if we can't culture the fungus directly. Now, this process is multifactorial. It includes the steps I've already talked about, and it also includes dental hygiene. Don't forget to floss. Now, the use of microbial agents, both prescription and non-prescription, should be considered, and this includes probiotics, many of which exert potent antifungal activity. And the use of what I term biofilm disruptors is also very important. Things like aged garlic extract, N-acetylcysteine, vitamin C, caprylic acid, berberine, even nattokinase, have all shown promise in this regard. We also need to assess for unusual risk factors of heart disease. Conditions like cytosterolemia, in which subjects excessively absorb plant-based cholesterol analogues, which are called phytosterols, interestingly of which seed oils are the dominant source, is associated with both premature and severe atherosclerosis. We should also consider testing for genetic factors which are associated with increased clotting risk, which surprisingly includes familial hyperlipidemia. And the next thing that we should consider is a big one: avoiding toxin exposure. And it can be harder than you think. Our whole environment is a heaving mass of toxin exposure. Take water. We might have forever chemicals or excessive fluoride. Research shows the potential for fluoridated water to cause mental retardation, amongst other things, which is why some Aboriginal communities have been provided with bottled water. Of course, this then raises the spectre of microplastic pollution, there being some reports that we can consume up to a credit card's worth of microplastics on a standard diet every week. And food also brings a host of other possible toxins, ranging from pesticides and heavy metals to moulds and artificial sweeteners, which incidentally have also been shown to cause oxidative stress. And it almost goes without saying that the very air we're breathing is polluted. And many of us don't realise how many potentially toxic chemicals we're applying to our skin, from makeup and sunscreens to toothpastes and shampoos. The fact is we're bombarded with toxins. There are some things you can do though. I personally drink reverse osmosis filtered water, and I avoid bottled water when I can. Even glass bottles often still have plastic linings in their caps and have been shown to have high levels of microplastics. I recommend eating as much organic food to minimise your pesticide exposure, and avoid processed and packaged foods. I have HEPA air filters, both at home and at work, to help reduce particulate inhalation, and I take care with what I put on my skin. I use tallow-based soaps, and I use hydroxyapatite-based toothpaste. In essence, I've probably evolved into what would have been called 30 years ago a hippie. Perhaps they were enlightened. We can even consider filtering our blood, a process called plasmapheresis, whereby some of the non-cellular or liquid portion of the blood is removed. And this has been proven to reduce toxic forever chemical levels in Australian firefighters. Of course, given the difficulties in completely eliminating toxin exposure, it may also be reasonable to consider supplementation with antioxidants, such as N-acetylcysteine, which, as you remember, also doubles as the biofilm disruptor, maybe coenzyme Q10, selenium, or melatonin, which is a potent mitochondrial antioxidant, all of which have been proven to offer health benefits in good quality randomised controlled trials. In closing, remember that atherosclerosis is not merely a tale of clogged pipes from LDL, but more likely the result of oxidative stress, probably infection too, which is magnified in the shadows of both metabolic disease and a toxic environment. To address it, we need to look at the root causes, and that's something that you can start acting on today. Thank you.